basically, this is the only instructions that I have from the manufacturer. So you guys can have this, copy it, whatever. I'm not a person that can actually read the instructions and say, oh, that's how you do that. So I don't really know exactly. Do we all know why BiPAPs are good versus CPAPs? Okay, BiPAPs, the whole deal with a BiPAP is CPAP is continuous positive airway pressure. So we're trying to pop open your airway. So what we're trying to do is in 3D open up that airway. So if you know, when somebody comes through a sleep lab, about 85% of the people end up with a CPAP. Well, if you think of a BiPAP as two CPAPs, so you're a box with two CPAPs. So you have an inhalation pressure and an exhalation pressure, okay? So we're just basically trying to move the diaphragm. So people with sleep disorders are COPDers, emphysema, something that their diaphragm is actually flattening out. So we're trying to get rid of some CO2. So I don't know if I would introduce that word. So what we're trying to do is basically non-invasive ventilation, meaning the patient has the respiratory drive, but you just can't move that diaphragm. Okay, so this is a quick and easy way to move that diaphragm in with the good air, out with the bad air. Is basically all this is doing. So the docs are going to have to try to figure out what pressure that's going to take, and how they're going to do that is basically with a pulse oximeter. Lots of times you don't have to add oxygen to it, because as long as we're moving that diaphragm, you know, they're getting oxygen, whatever. If you're going to add oxygen with this, there's a little T-piece, and I'm sure, I don't know if you guys have them in the hospital, sometimes they're blue or green, and we just put them in here, you add the oxygen here, and then everything is oxygenated from here on out. And then, so that's what we're trying to do. Okay, we're trying to move that diaphragm. Short-term stuff, hospital-wise, although there's people in home care that have BiPAPs their entire life. So that's what this machine does. What do I show you next? Let's start with the machine first. So you're going to plug it in. It's going to say therapy in the window. Okay. What that means when it says therapy in the window, for patients that are at home, they just put the mask on their face, a couple big deep breaths in, and it starts on its own. Okay. With you guys, you guys want to control that. You just reach down and turn it on. Okay. When it's on the patient's face, it's nice and quiet. Okay, so it's just the patient breathing, so you can hardly hear it running. And then, like I say, what we're trying to do is move the diaphragm. So what you want to do is, this can go basically the pressure gradient difference from 1 centimeter at difference, meaning like 8 to 7, or it can go as high as 8. So we can really, and that's going to be kind of patient comfort, and there's really no rules. Dr. Uramati always, when I call and asking for a change of order, he always asks me, well, how big is the person? So kind of a quick and dirty rule is, if you're 200 pounds, you're going to get a high pressure of 12. If you're not that heavy, you're going to be at a high pressure of 10. So what I'm saying is, this machine will go as high as 25/4. If you really wanted to inflate that person, you're going to have a lot of mask leak when you do all of that, that kind of pressure. But if you've got somebody that's 300-400 pounds, I mean, home care with a sleep disorder, and not in kind of an acute situation, we've set a lot of them up at 23/18. And that's insane. I mean, that's a lot of pressure. But if you're 300-400 pounds, you have to exert that much flow to lift that, stomach weight, chest weight, neck weight, whatever. So, I would probably start somebody out at, like a 12/5, check their sats. You're going to have them on a pulse oximeter anyway, and and see what they're oxygenating, and then just look at them. If you put a person on that, it doesn't take a whole lot of pressure to expand their chest wall. It really doesn't, and that's basically what we're trying to do. So we're trying to not tube that patient and blow off some CO2. So this is this little goofy manual. Tells you this, but I don't do any of that. So what you're going to do is go to setup mode. You're going to hold this and hold this at the same time, and it's going to beep at me.
Oh, okay.
And then I go back to setup, and I'm going to have all you guys walk through this, so it's super simple. So it has the first mode that it has is an auto BiPAP mode. What that means is that this crazy machine in-home will assess your airway and give you more pressure if you need more pressure. So if you're laying there and you're laying on your side, let's say, and your airway's half open, it's going to keep you at the lower parameters of whatever you set. If you lay on your back and you all of a sudden start obstructing, it's going to give you more pressure. Okay, so it'll do that in a CPAP mode, and it'll also do it in a BiPAP mode. So this crazy machine can go straight CPAP mode, can go BiPAP mode, and it can go auto BiPAP mode. What you're going to be short term is, I don't know, but if I was in-house, it would probably be a BiPAP mode where I'm guaranteeing that person a certain amount of pressure and then allowing that person to exhale. What's nice about this machine is if that person's breathing 10 times a minute or 30 times a minute, this thing has no rate to it, so that's why I say the patient's running the respiratory drive, and this is going to keep up to it. Okay, so it's more of a pressure, not a volume when you talk about ventilating someone. So because I'm gabbing too much, it's already went on. So I would go straight to the BiPAP mode, and you just go into mode, hit the button, and then you're scrolling down. So CPAP, BiPAP, and then get something more normal here. And just for the fun of it, it sounds kind of goofy and it's backwards to me. To ventilate a woman is higher pressures than to ventilate a man. Okay, and the reason for that generally is women have smaller airways. So I set women up lots of times that their normal is someplace between 11 to 15, where a man is 8 to 10, something. I mean, just because of the larger airway. Now that all goes askew when if the guy's 400 pounds and the woman's 120 pounds, then that makes a difference too. But a good number to start off is 12 to 5 is a good pressure difference. So once it goes back into therapy, you're going to put just turn it on, and it's going to rock back and forth. So that's how you set that. Okay, it's easy as that. The mask, then, to get a proper mask fitting, and the reason I brought this kind of a mask is because this particular one you don't have to have a lot of inventory. There's a petite, medium, or a petite, small, medium, and large, and they all fit on this frame. Okay, so you could just have extra sizes and then fit it on this frame. To get a good fit on your mask, what you're going to do is come across the bridge of your nose, basically down smile lines, and then across your chin here, and on up. And I have no idea what size I am.
Probably about that.
And this just sits, push it like that. The only place that person's going to exhale is out that port. This particular mask has a forehead pad adjustment, which means that when you start, you keep it on the as far out as possible. And what that does,
It actually, in the profile,
it tilts it tighter on your mouth, on the bridge of your mouth. And you're just trying to solve that leak. How this mask is designed, this is a gel mask. They actually come silicone too, but how this is designed is these flappers are supposed to be, fold down, so the air that's coming back actually presses back against it and holds it to your face. Then with the straps, all it is, I call it an eagle talon, but it just clicks onto here, and then to get out of it, it's just this, so it's kind of quick. And then you're basically just cinching down these straps tight enough so you stop the airflow. All right, any questions? And you guys can walk through all of this. Like I say, and you can create your own on, off, do this, adjust pressures.
We use this in Austin for, here's your COPD or your CO2 is 65 and your PO2 is 60. And to try and get rid of that CO2 to avoid intubating, maybe they don't want to be intubated, but it actually works pretty well. The other thing that you'll see happen is we'll do it for a couple hours and then recheck it, and is that they always drop their blood pressure. So don't freak out when they drop their blood pressure, because they will.
So are you using this kind of a machine, or do you what do you
whatever
use?
Respiratory.
Okay,
Yeah,
so it's just a BiPAP.
That's the thing, is I don't ever set it up. I have no idea how to decide what pressure is the right pressure, because I have people that do that.
Yeah,
So
and there's really not though.
my intent.
There's really not there's not like, okay, this person weighs this, and set them up on that.
Okay.
It's more of a feel, because there's so much, everything excess is gonna be exhaled. And because it's non-invasive, you're not gonna blow anybody's lungs. You're just gonna not get a good seal on your mask.
Okay. That was my other concern, is if we set it wrong, are we gonna take and blow a bleb on something?
No, because it's not like you're tubing them and you're getting a closed system. This is all open system. So the excess is gonna, long term, I mean, like not how you guys are doing it, but long term, the patient will wake up and they're swallowing all this gas all night long. So it'll be distended and it'll be gassy, or it'll leak around their mask. That's not gonna happen with you guys.
So are we gonna have just a couple sets of straps and different size masks? Or
That's
what
what
are
I
we
kind of
gonna have?
thought. I don't know. I mean, you guys are
So
gonna.
then how do you clean the straps? It's kind of like that.
If you were in the
Just
home
soak
and
and
if
wash
this is
them, or-
yours, yeah. Once a week you put it in whatever you're washing your dishes in. Mask, hose, headgear. But you guys can get the disposable of these. The other thing too I thought of is you guys don't need any humidity. I mean, the humidity is just long term. Okay?
Yeah.
So for short term, yeah, you don't need any of this. So what you do is do this, and then what the hospital has done is they've got one of these cheaper tables, and then they just bolt this basically down to the table. So then you have everything that you're going to need, and you're going to roll that in or whatever. And this is your cart basically, because lots of times if you don't, and you send this to the floor with the patient, they think it's theirs and they go home and they lose them. So they don't take the table home generally. So yeah, so that's kind of my thing, is that you're going to wash this out. These are, this is the gel, but they do make the silicone ones. They're a little tighter, maybe easier to clean, stiffer on your face kind of stuff. But
Are the straps disposable?
no.
No, you said that
Yeah, for home care,
Clean it up, use
for
the
home care,
straps
they're
for
$50 a
the
hit.
blood
So
pressure
no.
stuff and the sleep lab.
all that stuff, I mean, like even the sleep lab, we just soak it
Soak it.
overnight.
Right.
So I don't know.
I'm assuming that that's
So-
what they'll use. Is the
I
same.
wouldn't see it. That's like
And that's what I'm talking to Dr. Hageman about. It's like, I don't know, is this enough? I don't know if you've seen the Trilogy ventilator, but I don't want to use the word ventilator because people get freaked out about the ventilator. But, it's this big by this big. And then you guys can look at, even if you put them in a BiPAP mode on all the you could see what tidal volume you're given, what your airway pressure is, all of that's out in digital display. And it's super easy to run. It's easier than this because you can actually see what you're doing. I mean, it's the same scenario as far as, you go in, dial it to whatever, hit the button, that's your enter button and whatever, so.
Can you do that without having RT here though?
I don't know what that means here. You know what I
Yeah,
mean? I don't know. I don't know
that's
who
just
has
it,
the
you
rights
know.
to run that. Where, and that's maybe,
They get all
because he
excited
wanted
about
something,
that up in
right,
Austin,
that's,
because like, we can't send somebody with BiPAP to the floor, and Gold Cross won't take somebody with BiPAP, they'll take them with CPAP, it's a huge pain in the ass, and because it's such a nebulous, it's like
And-
this mysterious thing.
Yes, and it's so stupid.
Yeah,
Because a
you're making it
BiPAP
sound
is
like
two,
easier
a BiPAP is 2 CPAPs.
Yeah,
That's it, people. You're not dialing, with this thing, you're not dialing a backup rate, you're not dialing a tidal volume, you're not doing any of that stuff. This is just, if I had 2 BiPAPs here, okay, and I put a tube together, would you take them then? I mean, 2 CPAPs. If I
yeah,
had 2
I know,
CPAPs together.
but it's like this
I know
big
it, I
stumbling
know it,
block
I know
up
it.
there, and I thought, what's the big deal?
Because this, like I said, this box, you can dial it into the CPAP. So they wouldn't know the difference. What's the difference? You know, I mean, that's my argument,
Just
and
tell me
because
what's
I've, you know, yeah,
I've had to
I'm-
call the chopper before, when I've
Okay.
had somebody on BiPAP and had them stable, and didn't wanna flip them to CPAP because they were stable on the
Right.
BiPAP, and.
So now
Gold
this
Cross
is in the
was stable.
CPAP mode.
Yeah.
Sorry, it's a CPAP, but I assume.
So yeah, no, that's
hospital
the
got it.
problem,
Do
and
the
that's what,
other-
that's what they were just like, okay, no, we wanna keep it simple, and we just wanna get that tool.
Well,
And
it
that's
gives
what
us a
I was
tool,
told.
because we have all these
They don't put it in
COPDers
BiPAP,
that
and it
don't
was
wanna
like
be
instant.
tubed, that
Oh,
don't
yeah.
wanna go anywhere, but it's, we know that
And if they had their.
that will help them,
And
and
if they
it
were on
does
their,
help them.
yeah, it helps huge, and if they were on CPAP and they came in
I
and
would-
you
I
flipped
would
them to a BiPAP, you could use their mask hose and get here.
Especially some rules.
True, but a lot of the machines don't have that capability, do they?
But, no, I mean, if they had their CPAP at home,
Right.
if you would have their mask hose headgear, you could use theirs into the BiPAP.
Oh, their headgear.
Yeah.
Yeah, I
Yeah.
thought you meant their machine.
No.
So let's say this is successful, how do they decide, like,
Nobody knew how to turn it off.
when somebody needs home BiPAP? Is that done in the sleep lab, or is that,
Right now, it's done in the sleep, but there is insurance companies that say you don't have to have a sleep study. You know, you can go to just like an apnea link, and then go straight to this. Right now, nothing's paid for when you go with this. But right now, Medicare says if it's medically necessary, okay, where you have to, the patient's CO2 rises, you know, all of that stuff, and
Well,
you
that's
write
what's-
medically necessary, they can get the Trilogy ventilator at home
Oh, okay.
before they can get a BiPAP. That's how messed up the rules are right now.
Well, I was just thinking if we have recurrent COPDers and they tend to CO2 retain, and then they come in a mess and we get it back down, and then they come, you know, maybe they would
They would-
benefit
they
from
would-
nightly
Yep, they would
BiPAP.
end up with, and we call it non-invasive ventilation,
Mhm.
and because of CO2 retention, and it's Medicare, gives us about $1,300 a month for the home ventilator, non-invasive ventilation. We sadly, we're setting them up probably once a month.
Uh-huh.
It's a lot of money. It's a lot of money because the powers that be in Washington don't understand the voodoo behind the BiPAP. That's all I got, if there's no questions.
That T piece, because oftentimes they're also hypoxic, and the T piece, I'm not, do you guys know what he means?
Mhm.
Because we're gonna want the oxygen, but
You
No.
know,
if
like
we
on
do
the,
it
you
for-
know, like on the CPAPs even, you know, where it's got that little piece and it's got the little knob, you put the oxygen in. Oh, okay. That's how it works.
Because you're for the
Yeah,
1230
I was
insurance,
gonna
I'll bring
say,
mine.
It was like,
It's out in my car.
Room 8 has.
Yeah, it's just a little
I
T
don't know
piece,
if we
it's
have
ours
extra
in the
ones
home
in
is
the
green,
sleep
and
lab, we
you
just
put
have it
your
on our machine.
oxygen.
I
The other thing too,
what do you do
though,
your O2 flow at though? I mean,
Very good.
but so if we've
Okay.
got somebody at a 60 O2,
you're gonna do a pulse oximeter.
yeah.
The one-
This thing is kicking out about 40 liters a minute.
I don't think we have extra.
Okay, so if you come along and try to impress me with 1 to 2 liters, that ain't happening. Okay, so because of the flow of this, so you're gonna have to go. CPAPs at night or BiPAPs at night are 4 to 5 liters while they're sleeping, and maybe 1 liter during the day because
Okay.
they're doing cannulas.
Uh-huh.
Just because, and I tell people, okay, if you're gonna put black paint here and I'm gonna pour in 1 liter of white paint, it barely turns that paint gray. It's so, but that's what you got a pulse oximeter for. We're
So
what
in
are you
an
gonna
emergent situation,
do? Crank it up,
crank it up flush and,
Yeah, because you're not gonna notice the difference, because of this, because of that.
cause you have so much flow.
So much flow.
It dilutes your oxygen.
Yes, 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 yes. So you're gonna just say, well,
Just
what
crank
I
it
want
up.
as a therapist or a nurse is tell me what you want your SATs to maintain. What's your minimum SATs? Okay, and then give me, then I can say, okay, well, it took me 8 liters to get this person to SAT at 92. I wanna know what you want the SAT to be. If you're happy with 88, I'm happy with 88. If you're happy with 92, I'm happy with 92, and whatever it's gonna take to
I'd
do
be
that.
happy with anything better than 70.
No, but I mean, that's-
70, what is that?
Anything
No, but
bigger
that-
than 85 is
Yeah,
good.
but then we don't have to call you to say, okay, I gotta go from 2 to 3, 4, whatever, no, because you don't wanna hear about that. It's like, maintain, give me a SAT that you wanna maintain.
Okay.
That's it. And if it's a if it's a CO2 person, set your sights low. I mean, anything around 90 would be fine. Because you're trying to blow that CO2 off is what you're
Yeah.
trying to do. And I don't know.
But I think we're I'm looking at it in an acute situation.
Right.
And
And
I'm
that's why I'm trying to change
I'm
my
trying to
brain.
get them
Emergency in the ER.
oxygenated and
Yeah.
get their.
Right. And that's why I'm trying to change my brain to go.
Till the helicopter comes to get them.
Right.
Yeah.
So,
Well, and a lot of those didn't want to be.
well, because lots of times those guys, you tube them and there's a certain percentage that'll never come off of that. So it's like,
A lot of them don't want to be tubed,
right.
but.
A lot of them don't want this mask on their face, but what are you
Well,
gonna do?
that's true.
And the other thing too, though, is if you can, I mean, a lot of people that I set up home care wise, they hate full face masks. Okay, so even if they can keep their mouth shut, even with a nasal mask, even with a BiPAP, you're still gonna do good. You're still gonna move that diaphragm, but you got to keep your mouth shut. And that's when I threaten people with chin straps and everything else. You got to keep your mouth closed. So, but a lot of it is, calming the person down and, this is good for you, this is good for you, this is good for you.
Is there anyone that can't
Yeah, I was
put
gonna
on
say.
any disease process, any age limit? Is it okay for,
Well, you just want to,
pediatric
like.
respiratory distress if you have
Oh,
a small
heavens,
enough
yes.
mass?
Oh, yes. And kids do the same pressures as adults. It's not like it's any parameter difference. Home care long term, I probably have, I have a 2-year-old and I have 6. I mean, and it's, when I come into the home or they come to see me, it's like, how am I going to talk to these people? How do you convince them that this therapy is good for you? And that's tough on a kid. I always think it's tough on a kid, but these kids are so oxygen starved. Like the little 2-year-old is like, okay, how am I going to convince this crazy kid that he's going to need it? And I'm sitting there and he's sitting on mama's lap, and as soon as I turned that machine on, he just leaned in like he was it's like, give me that. I was like, yes, I'm done now. But yeah, that was, so yeah, that, it's, you may have to hold the mask on, you may have to do a lot of, comforting and, talk people off the ledge type stuff, and this is good. The thing that you notice though is, even in acute care, when you turn this on, there's a lot of airflow there, okay? So you guys may want to, there's a ramp button, okay? So if I come at you with a pressure of, 12/8, and I come at you with this is a lot of flow blasting at you. But if I can turn it on, even with that 12/8, hit the ramp button, it's gonna start it at, like 4/6, and within 5 minutes it creeps back up to that high pressure. So it's a way for the manufacturer to actually have people like not get anxious, and it's like, oh, this isn't too bad, and but within that 5 minutes, and it can change the ramp time is what it's called. You can actually change that from 5 minutes to 45 minutes. So in acute, you'd want it to ramp up rather quickly, and at home, it's like you hit the button, and now you have 45 minutes to slowly build up to that therapeutic pressure, which is very cool, because then it's like, I mean, even, mom or grandma, it's like, whoa, this is way too much, I can't deal with it, and they start ripping it off their head, or if they're just doing a nasal mask, they open their mouth instantly. So by hitting that ramp button, it drops it down to that lower pressure, and you can actually talk through the mask and that kind of stuff if you want. I mean, it's just a way that the manufacturer's built in, kind of a non-fear factor type thing.
So you hit the ramp button, but you really didn't need to, because you really need the
Right,
full
right,
thing. Can you
right.
undo it? Can you
Yeah, what you're gonna do
Unramp
is,
it?
yeah, no, you're just gonna turn it on and off again, and it resets it to whatever
okay.
you set it to.
Okay.
Yeah.
So every
Yeah,
time
my
you
like
turn it
would
on,
be
you'd
at
have to hit the
45
ramp if you
minutes.
wanted
and
it.
Right,
It
so
resets
it
every time you
defaults to your therapeutic flow, and then you hit the ramp to kind of talk people off the ledge, and then let it go again. But as soon as you shut that off or turn it back on, it comes back.
Comes back to that.
Whatever you set it to.
That's an easy fix.
Yeah, yep.
Awesome. How many, we're gonna have 2 of these? No.
Oh, I have no idea. My thing's here just to
Up
show
to
you
you,
guys.
Mark.
If that's
How
what
many
you
you
want,
want?
Marcia asked for that.
One each room.
I don't know,
think we
I
need
don't know
one
how
in
much,
the ER
I don't know how
and
much
one
you use
that
it.
could be in use down here, because if you have somebody that
You
needs
almost need
it,
to.
you almost need 2, because if you're gonna offer the, as a service,
And then I don't know
Unless,
what
like,
your, you know, the
let's-
bean counters are gonna look at money,
yeah,
okay? So used one of these dogs are $2,100.
How much? 21.
that's not bad.
That's not
And then
bad.
and then I don't know, you know, what their reimbursement is for that, you know, that's somebody else's problem,
Yeah.
but, yeah. New they're 3
If you get 2,
apiece,
that's under the 5,000.
but he's
So
asking for
let's
2
say,
used ones.
what if somebody needed it on the floor, is there a method to say, okay, they use ours until, and then they end up
What we do with
purchasing
Big
it or
House, West Campus and Mercy, it's a $35 a day charge. So, you know, ideally what you could do if you knew it was gonna be long-term for a couple of days, you call us up and we would deliver them here. And then you're gonna be, it's a $35 a day charge, so if they're here for 2 days, it's relatively cheap.
They'll let the bean know.
Right,
I just wanna
right,
make
right.
sure it's not stuck on somebody down here, we don't have to rip it off somebody.
Right. No, I
Throw
would
it on
have-
somebody else back there.
No, I would, that's
Quick,
exactly.
take a breath.
I'll be right back. Keep your mask, you're gonna need it, I'll be back. Perfect. No, but I would definitely have one in the emergency room and then have, you know, if there's one on the floor type of thing. Or you have one and then as soon as that's in use, you call us for another, I mean, that kind of thing or
The only
something.
problem is
However.
you never know when that acute is gonna come into the ER with us.
Well, but that's what I'm saying, if you have one on the floor, you
Yeah,
need
there
to have
has
one
to
in
be
the
one
closet.
each.
Yeah,
True,
I mean,
yeah, that's true.
but
You
is
know,
like
we-
5,000 is our grand budget where we have to budget it out? If it's under 5,000, is it 500, it's 5 something.
We don't worry about that,
The capital budget, yeah.
The cap, I think if it's over 5,000, it's capital budget, isn't it?
We'll let Jill worry.
Cause the other thing too,
So I said
that I
if
was
2 of
talking
them,
about
that's nothing,
Megan
ambulance can
about,
budget their own.
Yeah,
it's, you know, the ambulance, you could plug this into your ambulance and drive that person all the way to Mason City.
so you have the same model for Weaving, correct? As far
This
as
is the model.
I don't know
This
if
is
it's
the
okay.
model that you guys use on the, this is what you use at Mercy?
Yeah, we
Okay.
sell hundreds of those.
Yeah.
Yes. Yeah, like I said, but they have theirs bolted on a table so they don't run away with it.
I think that's a good idea too.
I think so
They
too.
tend to- Those
Cause
are,
otherwise people
you
lose
fit
this.
in a bag.
Yeah,
Yeah, and
Really
they have
easy.
carrying bags like this and off they go. So.
it's hard to carry a table
Well, and they
without
might
a
think it,
I have
they
no
might think
problem
it was
doing
theirs, you know, they were
trucking
using it, so.
I know, right?
Well, and there's all kinds of scenarios that, can we take this home until we have our sleep study? Can we take this home until we, and it's like, sometimes it's like, sure, I think it's yours. No, it's not. So yeah, no, that's what we do at the hospital, is they have this, they have it bolted to the floor or bolted to a table. They do use the humidifier, because it sits on here, and if it just stays dry, like in the emergency room, you don't have to put water in it. I mean, it just
No.
sits, but if you send it to somebody's room, then you start using water. Cause as soon as you use this overnight, because of all the airflow, you dry out. I mean, you're in front of a reverse vacuum cleaner and you're gonna dry out. So. That's it, but there's no voodoo, there's no magic, there's no,
What's the worst thing that could happen?
you drop it and it breaks.
Okay.
I think she meant with the patient.
I know that's what she meant with the patient, but you can't, the worst thing is, it's your sales pitch and talking to the patient. Now we have to either do this and just be patient. You know, when my setups, it's like, you know, you have this sleep disorder forever, most of your adult life, so, you know, you gotta give me more than a week. You gotta help me with this. Same with this, your sales pitch is that, you know, we don't wanna put that tube down your throat. Can you just breathe on this for 5 minutes? Let's see how we can do, and let me adjust the pressures.
That's right,
Okay.
and that ramping would be kinda nice, if you have time to.
See, and that's the beauty of, and I don't know how it would work in acute, but that's the beauty of that auto. You let that machine, you know, start out low and go in the auto range, okay? You don't wanna start the auto so low that people will pull off their masks faster if they're suffocating than if it's too much pressure. So you wanna start off at that, you know, 8 to 12 range, and then you can always ramp it down to the lower if that's too much for them. But if the patient, and I'll do that when they come in and to do a setup, I'll say, especially if I think the pressure's low, you know, I mean, I've been on a CPAP myself for 6 years and it's a pressure of 11. Now I get Dr. Uramati or somebody dialing somebody that's bigger than me, and we start them off at 7. It's like, dude, you gotta sit here a little bit because I'm thinking you're gonna suffocate. So let's just turn this on, and most of the time they'll go, because they'll try to keep getting that tidal volume, but you're only at 7, so you can't have the rest of it. So it's like, no. So then, you know, I'll turn it up and turn it up and turn it up, and then call in and say, yeah. So that's the trick behind this. It's like, well, I'm not getting enough air. I'm still not getting enough air. Turn them up, because it's just going to blow around the mask. It's going to blow out the exhalation port farther. It's not going to.
That makes me feel better. I don't wanna blow anyone's lungs out.
It's not a closed system.
That's good.
You know, it's not like we're tubing that person, pumping up the cuff, and then we're going to bag them. You don't do that. It's an open system. We're trying to heat the room, but the door is wide open. It can only get so hot in here.
Is there a chart, like something to refer to at all, to like the weight of the patient?
No.
Started this.
BMI, something like that.
Yeah. No?
No. Because you can't see what your airway is.
Okay.
You can't see what your frame is. You know, I have guys come in that are like huge people, and I gotta have a large mask, dude. Your nose is small. I mean, so I can't, just because it's heavy on the outside, I can't tell what's on the inside. I don't know how big your tonsils are. I don't know how far your tongue falls back. I don't know where your soft palate comes back, you know, that's going to obstruct your airway. I can't tell any of that stuff. So it's like, let's just see what it takes.
And the guideline for the mask, like instead of getting one out, be like, oh no. too
No,
big.
there is.
Oh,
There is.
no.
No.
Do you
There,
measure,
no,
like, here
there
to here,
is.
and then
There
this
is tools for that.
4 inches.
Oh.
And
is
I
large.
can get tools for that, where you just
Oh,
walk
that'd
up
be
to
good.
somebody, and like with this
There's
one,
a plastic one in CPAP that
Yeah.
just measures from here to here and
But
tells
so
you
if this one is on the back of the bag, it's very high tech. So what you do is kind of go from here to the bottom of their eyeball.
Say that again?
So if I was gonna see where this bottom of this guy's eye is, so you're gonna look to here and the bottom of the guy's eye, okay? And that's where you think, here, so put this line here, and then you go to the bottom of the guy's eye. See, here's your starting point, and then the bottom of their eye. This would be the
Oh.
medium if it matched up there.
Bottom of your,
Just kind
I
of
mean,
look at. So you're looking at here is where you're gonna put that arrow,
Bottom of the
Okay.
lower lip.
and then you're gonna look at their eye, okay? Like where their
So this is
eyeball
the
ends,
other, like, cut
and then
this
that
out.
would be a medium or.
okay.
Yeah, line her up.
So you go here, you'd be like this one.
Because if you go too big, it ends up being here, and then it comes across their eye, and it's hard to solve that, you know, spot. So it's kind of a, yeah. So there
Oh, you
is,
know you're a smoker.
There is a lot, they're called gauges, and there is all kinds of gauges that I can get you, that's fine. But they truly are on the outside of the bag.
Well, that's helpful.
Make sure you just cut it out so you don't put the bag over their head.
If you just put the bag over your head and skip the BiPAP. Yeah, and so,
Breathe,
but if you guys, these things are washable, so it's not like they're gonna go very far with the patient. In
No.
in the sleep lab, they seriously wash these things for months and months and months. So when they come to me in home care, it's fresh, it's new, it's like, hey, I like this. It's like, well, yeah, but you might have been number 50 or 100 that had that mask in the sleep lab. So yeah, so it's not, you're not wasting. Because you're gonna have this in a Ziploc. It's not gonna be in its new bag every time. You're gonna just have a storage of those and say, what's gonna work, what's gonna work, what's gonna work. So it's not like you're gonna have a lot of different inventory to try.
So the masks aren't, the masks aren't supposed to be?
Yeah.
No, heavens
Clean
no.
'em.
That's $240.
So then when the patient leaves here, it has to go with them, or
No,
usually
it's
they
not.
might have it
No,
on
it's
and swaps it over? I mean, you
Oh,
know,
when they're transferred?
yeah.
Yeah, I don't know. You guys are have to develop some sort of. It's gonna.
Good thought,
it's-
'cause those will
it's
be
gonna
gone
be-
in a heartbeat.
Yeah, it's gonna be
Yeah.
built
Yeah.
to
Like
you,
that.
and somebody's gonna have to keep inventory just like everything else. Just like if you use an ET tube or something,
Like the-
somebody's gonna have to do that.
IV pumps,
Mhm.
ambulance takes them, they bring them back.
Oh, there you go.
Yeah.
But this is their BiPAP.
But this is gonna be,
What,
You
can
may
we
not
work
see it
something
again.
out with Mercy that they would
send one
give
back
us a
if we-
mask if we,
If we send one with them,
I
they'll
mean, if
send
they've
one
got
back.
one that's fitting
Yeah.
The
well.
problem is,
Who's gonna govern that?
Well,
yeah,
how
the
about
left
when-
hand doesn't
I
know what the
mean-
right hand's doing, and the people that have the mask wouldn't know if this person.
But when
came
the
to
ambulance
emergency
comes to
room or
get
not.
them, they would have to take ours off and put their own on.
They wouldn't have one. They wouldn't
They
have
don't
this.
have
They
one.
would have like a simple face mask. They wouldn't have
Well,
or they would have.
But if our
CPAP, so
BiPAP,
wouldn't they have
but
a
if our
BiPAP
ambulance
too?
came, if they
Maybe
went
like,
the same system, you would think that they
Yeah,
would have a
chain it
mask
to a
just
table, whatever
interchange.
table we
Right.
decide to.
So that is a different manufacturer and a different mask. So you have a Ford, this is a
But
Chevy.
it still works to tell, I mean, we
Yeah.
have those masks, but we have these masks too. It still gives us an idea
It will.
what size.
But I'm just
they
saying
need.
that's a different manufacturer, so it's
Right.
not gonna be exactly. Just to put a stick in your spokes.
So
So when the helicopter comes, she's just gonna tell them you're on your own now.
Well, Mayo brought theirs in
Yeah,
that
Mayo
day,
brought
and,
theirs.
They would switch
and
it
I
They,
was
they
like,
bring their BiPAP.
put it on, and
Good.
that's where I think Dr. Haig would probably.
But the problem
saw
is
the
if we,
improvement
They
in
go
the
by
if we
CPAP
do it and they
off,
go by
BiPAP on,
ambulance,
and
we're
we
gonna
went
lose
from
that mask.
low 80s to high 90s, like just
If our
like that.
ambulance
It was
has
like,
that machine, I think they
oh
should
my
bring,
God.
I mean,
Well,
bring
that's
their
what he said.
machine
He
in
said
with
you
them,
have
switch
three
it out with
people in
ours,
a
so that
short
we always had
time.
one
Yeah.
in the
Yeah.
yard,
This
is
is
what
why
I
in the
would.
world
But I
can't
don't
we have
think
a
the
BiPAP?
ambulance
I said,
has
you
one.
can.
They don't,
Right.
if we
I
went
get
with
rid
this,
of them
I
every
think they
day,
should.
absolutely. You guys should have one.
Unless it's out of their
Because
scope of
Harold-
practice that they're
I
giving
figured
the
you'd get the ball
BiPAP, that's the
rolling.
Well,
hiccup.
see, I
But
think
Harold
that's
would've-
what, I don't know if that's what the hang up in Minnesota is.
Oh, sure.
Is it's
Oh,
out of their
sure.
scope
She
or?
has to have an
Too
check
bad
into that to
because
see
we
if
didn't
that's out of
have
their
any
scope of
choice.
practice, cause then if
It
they're coming in
shouldn't
and the
be, they're
person's.
doing vents.
That's dumb.
They can
They
do
do
a
that.
vent, they can do a CPAP, why, what, I don't
Yeah,
get
it
why
shouldn't be,
BiPAP
but
is
you don't
such a
know.
big deal.
But if we go with this, then I think they should have that in their rig too, and then when they come in and they know the person's on BiPAP, they bring in theirs and switch it out, I think it should be
At least.
If
tattooed
If
with
they
their
have
name on
the
the
new ones
side,
like
and,
this, like I said, they can go CPAP, BiPAP, AutoPAP, whatever.
so I really
In
think the rig
different
should go with those two.
But it's when they get up to the ER in Rochester.
Oh, we'll have them.
They'll flip them over to their stuff then.
They
They
do, but
should.
you know what, they'll unhook it, and there goes our